Good evening and welcome. It is my great pleasure to welcome you all to this AstraZeneca webinar titled What Do Physicians Need to Know About Lung Cancer? I am your moderator, Dr. Apoor Verma, Medical Advisor Lung Cancer with AstraZeneca. Now, the objective of this webinar is to provide our listeners through the presentations and discussion on what you and your colleagues need to know about lung cancer. As we all know, there is a high incidence of lung cancer in our country, and unfortunately, most of the patients are diagnosed only in the later stages. High suspicion and early diagnosis may lead to improved survival of lung cancer patients, and you all physicians play a vital role in making huge difference in the survival of such patients. We will cover a list of topics through a couple of presentations, which our esteemed speakers will present in detail and share their insight on how we can increase the survival in these patients. What are the unmet needs in the early diagnosis as well as the management of such patients. One quick housekeeping note. We encourage that you submit any questions you have in the chat box, which we will take up after both the presentations during Q&A segment of this webinar. For today's webinar, we have distinguished experts from the field of medical oncology and pulmonology in Dr. Ranga Rao and Dr. Prashant Chhajed. And I'm sure next 1.5 hours are going to be a great learning experience for you all. So it is with great honor that I now introduce to you our first speaker, Dr. Ranga Rao, who will be speaking on prolonging survival in lung cancer and addressing unmet needs. Dr. Colonel R. Ranga Rao is an eminent oncologist who served in the medical fraternity and armed forces for approximately 30 years. Currently, Dr. Rao is chairman of Paras Hospital, Gurgaon. He was previously associated with Max Super Specialty Hospital in New Delhi, where he was Director of Oncology Services and Senior Consultant of Department of Medical Oncology. He specializes in all major lung cancers like lung, breast, ovary, esophagus, lymphomas, and many more. Dr. Rao's skills lie in chemotherapy, targeted therapy, hormonal therapy, supportive care, as well as palliative care. May I now request Dr. Ranga Rao to please begin his presentation. Sir, please.
Good evening, friends. It's a pleasure to be talking about the lung cancer, which is one of the commonest cancers in the world. And in India, it has picked up a lot, and it is number 2 in the men. And we will be just listening to various things new happening in the field of lung cancer. So right in the beginning, I would like to just say that the lung cancer has changed so much. In the last 30 years, when the people were dying within few months, now they're surviving for many years. But then we still have a long way to go because we are getting the patients in very advanced stages. So let us see how we can improve upon it. So the outline of my presentation will be to give you a glimpse of the epidemiology of the lung cancer, both global and Indian, then types of lung cancer and their survival, management and recent advances in lung cancer, both resectable, unresectable, and metastatic. What are the unmet needs? And then most important thing is the role of primary care physicians. Now you will be wondering as primary care physicians, one may not be involved in the direct management of the lung cancer. So what is the need for you to be aware of the lung cancer newer advances? So let me outline my logic as to why we are doing this. Number 1 is that this is a very, very common cancer. Number 2 is that it can be easily confused with the pulmonary tuberculosis, which is more common than the lung cancer in India. So therefore, we must have high index of suspicion, very much. And then early diagnosis and prompt referral is of the utmost importance here in the lung cancer. Prevention and screening is possible, especially for the prevention, probably the lung cancer awareness and anti-smoking campaign, that is what should be done, as well as screening of the high-risk population, that is very much possible at the primary care physician's level. Optimal referral to the oncologist and the pulmonologist at the right time, at the right patient to be sent, and then brief the patient while the patient is on treatment and very investigations, he will have lots of doubt, and because he belongs to your area and he has got more confidence in you, he will be asking you questions. So there, your briefing of the patient about the importance of various tests and treatment, I think, is required, and he will trust you more than the oncologist whom he does not know. And then also, while the patient is on the treatment, he's taking care of him during the follow-ups, various complications, recurrences, and most important thing is coordinating with the oncologist about his care. So ideally, what happens is the primary care physician becomes a partner in the management of the lung cancer. So let us see what exactly is happening on the scene of the in the world and in India. In the world, it is number one cancer, and then it is number one killer. And most important to realize is the case fatality ratio is very, very huge. Almost 70 to 80% of the patients of the lung cancer die in the first year itself, because cumulative and that particular years. And this is followed by the other cancers. So lung cancer is the most important thing. At the same time, in India, the incidence is very high, and in the men it is number one, and then in the woman it is, while it is a breast cancer, numbers are almost the same. Whereas the cause of the death in India also, it is lung is number one, and then it is a leading cause of cancer death, accounting for almost 19% of all the patients of cancer. And then this represents close to 1 in 5 of the cancer deaths are because of lung cancer, which is huge. And then this is the fourth common overall in the cancer in the incidence rate among in India, and second most common in the males, third most common cause of the death in India, and it is the most common cause of death with cancers in India. The average age at which it is diagnosed is about 55 years, which is one of the most productive years in India and elsewhere. And we almost have about 70,000 new patients diagnosed every year, and 63,000 patients die each year. The mortality is of the case specific mortality is very, very high. Let's also now learn what are the types of lung cancer and their survival. In the when we were all in the old MBBS days, we all learned that the lung cancer, it is of a two types, small cell and non-small cell. And before that, we all know that this comes out from the respiratory epithelium, that is the bronchi, bronchioli, and alveoli. And then the tumor classification goes as small cell and non-small cell. That is what we have learned over the period of years. The non-small cell is subsequently further divided into squamous, large cell, adenocarcinoma, and alveolar, and other types of carcinomas. And most of the cancers are non-small cell, about 85%, whereas 15% are only about small cell. Coming to the small cell in very brief, that accounts for about 15% of all cancers, occurs exclusively in the smokers and more prevalent in the women than the men. Small size the cell spread and meta is very, very fast. Actually, the doubling time is very fast in these patients. They come and go very fast. Their survival is very small, and their lesions commonly originate in the central part of the chest. Initially very chemosensitive, it appears that we are dissolving the tumor, but then subsequently they become resistant and spread very fast, and they ultimately have a poor prognosis. This is the histology of the adenocarcinoma, the squamous cell carcinoma, and the large cell carcinoma. And these become together, they comprise about 85% of all the cancers, mostly in the smokers as well as in the non-smokers. They metastasize relatively slower, and especially the squamous cell carcinomas. The non-small cell carcinomas are not only divided into the histological subtypes, but today there is a molecular classification which is very, very important, and the whole treatment actually revolves around these molecular subtypes. Carcinoma can have multiple, very, very multiple types of the genomic markers, which is EGFR, ALK, HER2, BRAF, and so on. And then all these markers are there. For each one, there is one particular molecule which affects which can actually treat these kind of cancers. Similarly, squamous cell carcinomas, small elements are there, about 10 to 15% of them can have these mutations. And for each mutation, we have an antagonist for that. So more than 50% of these adenocarcinomas, they have identified mutations, which were hardly any few years back. We learned about 15 years back about EGFR and ALK, and now we discovered almost all of them. Only 36% as on today do not have mutations. All others have mutations of some or the other. And then we have the drugs against each mutation individually. And that is the reason why we need to know these kind of mutations, why they are there. So how does one approach to the cancer? I'm sure all of you are seeing the patients who come with the cough, hemoptysis, chest pain, fever, weight loss, and systemic symptoms of the cancer. And when you suspect and then send them to the oncologist or the pulmonologist, what happens? That's exactly what we're discussing about here. So after the suspicion, first important thing is the histological diagnosis, which is a must. And then after that, we do the staging of the disease. We must know what stage. Stage 1, 2, 3, or 4, and in the small cell it is limited or the extensive stage. And thereafter, once we know the stage and the histology, then we formulate the treatment goals. We offer the treatment to the patient, and while on the treatment we assess the patient and then have a revision of the treatment if required and continue on maintenance. So that's how it goes on. During this treatment he will be having complications, and whatever complications are there, they're managed. So this is the general way of managing a cancer patient. Let's see, when the patient has a non-specific chest symptoms, the cancer suspicion, they go to from the primary care physician to a pulmonologist or an oncologist. Important thing is the diagnosis, biopsy, and the staging. And this diagnostic workup takes at least 5 to 7 days. That's very, very important to realize, because one may be wondering that there's so much of delay in diagnosis and staging, but the various investigations, including the bronchoscopy, the biopsy, the PET scans, CT scans, MRI brains, and so on, they do take some time, and you're all aware of the appointment systems in each hospital. They take about 5 to 7 days, which is very quick in India, and other places it actually takes much longer time. And thereafter, a multidisciplinary tumor board happens, where all the treatment, the specialists involved in this meet and discuss about the management, and then the treatment is offered to the patient, and thereafter the follow-up is done of these patients. Let's have an overview of the management of lung cancer, how the stage wise. So I won't go into the stage details, but then I just want to give the outline of the stages. Stage 1, when it is limited and small in the lung. Stage 2 is a little bigger than stage 1, but not as big as stage 3. Stage 3 is got some nodes which are involved, as well as it is big. It's a loco-regional disease. Stage 4, once it has gone into the same lung, pleura, or the different places, accordingly it will be called as M1A, M1B, M1C. So stage 1 and 2 are completely treated by surgical resection, as well as followed by most of the cases by the adjuvant chemotherapy. And the newer advances which are happening are, instead of surgery, patients could be offered radiation, or the surgery is done by the technology called as a VATS, that is video assisted thoracoscopic surgery. And the investigations are going on whether adjuvant, that is post-operative immunotherapy, or EGFR TKIs are being given. That's what is the investigation on. Stage 2 is treated in the similar manner, except that all patients of stage 2 will be treated after surgery by the adjuvant chemotherapy. At the moment, that's a standard. Stage 3 is, some of them are operable, some of them are inoperable. And then these patients who are operable, they will go for surgery and the adjuvant like the stage 2. But those who are inoperable in the beginning, they will be going through a chemotherapy which is called as neoadjuvant, followed by the assessment and surgery, and then for further adjuvant chemotherapy and radiotherapy. But those patients who are not operable, they will have the concomitant radiation and chemotherapy. That is, both radiation and chemotherapy are given together, and that's one of the advances which has made. Apart from that, we are now also having a maintenance or consolidation, the monoclonal antibody with immunotherapy. That is the new advance which has happened. Also, the TKIs, that is the tyrosine kinase inhibitors, that is the antagonist to the various molecules, that is EGFR and so on, are also under investigation. For stage 4, we have the targeted therapy, the immunotherapy, and chemotherapy. And the key to the whole treatment is around the biopsy and finding out the biomarkers and what is the exact treatment. And that's a personalized treatment. That is a key to the stage 4 treatment. The surgery radiation can be used for the local control as even required, and new combinations are being investigated: targeted therapy with chemotherapy, chemotherapy with anti-angiogenic agents, chemotherapy and immunotherapy, and so on. Here, the survival, if you see stage 1 and 2, they have about 70 to 90% or 50 to 60%. And as the stage comes down, that is the higher stage we reach, the mortality or the survival rate comes down. So that is one key point. Here, in globally, the majority of the patients are diagnosed in the early stages in the global, and there is stage 1 and 2. A lot of these there are resectable are about considered about 25%. Stage 3 and 4, they are about constitute 75% in the world. So in other words, majority of the patients are diagnosed in the late stages despite all the advances that we have. This is the point which we want to understand. Whereas in India, the situation is somewhat much different. Against the 25% of the patients who are eligible for surgery abroad, in India, the percentage is about 5 to 10%, at best 13, 15%, depending on the centers that we are looking at. And a lot of patients actually come in advanced stages. Unlike 75, they're almost 80, 90 to 85% of the patients present in the advanced stages. Now, this is a tragedy of the lung cancer. So here, all our role as medical people is there to diagnose them much earlier than what we have. And we all know the cure rate or the 5-year overall survival rate, they decrease with the increasing stage. In the stage 1A1, that is 92%, and it drops down steadily as the stage becomes higher. And then in stage 4B, hardly any patients survive to the end of 5 years. But today, with newer management, things are changing, and we hope that patients are going to live better. Now, when we have the management of non-small cell lung cancers, we have a multidisciplinary team. No single person can claim to treat these patients. One of the important members of the team is the pulmonologist, the radiologist, pathologist, cardiothoracic surgeon, or a surgical oncologist who is trained to do the thoracic surgery or the lung surgery, and then a medical oncologist. And I would say one of the most important member of this team is a primary care physician, who is very important part. The whole thing starts from him. He diagnoses and sends them to the physician, the oncologist or the pulmonologist. So therefore, is one of the most important part of this team. So stage-wise management, if we just go through it, and the management of the early localized is basically here. You can see this small tumor stage 1, a little bigger stage 2. These are all managed by the surgery, and then stage 3 is managed by the chemotherapy. When the lymph node is involved, chemotherapy and the radiation and the chemotherapy together. So the resectable one, whenever there's a resectable lesion, surgery followed by the chemotherapy. If we just go through the whole algorithm once again here, we diagnose the patients. After that, he undergoes this staging and a decision whether is it resectable, operable or not. And then a multidisciplinary team happens. If it is resectable, the patient goes straight for surgery, followed by the chemotherapy as in required. If the patient is having unresectable disease, he undergoes the neoadjuvant chemotherapy, that is chemotherapy before the surgery, or radiation, both of them together, and followed by surgery, and then the adjuvant chemotherapy can be given. And in case the early stages, no adjuvant therapy is given if it is very, very early. Molecular testing is not done in the resected tumors, but this is an investigational modality as on today. So after the initial treatment, more than half the patients of the resectable types also experience the recurrence within the first 5 years, and that's one important part we need to do. And for that, so 40 to 50% of the patients recur over the period of time in the 5 years, and how to stop it is the issue. Though we are giving chemotherapy, maybe checkpoint inhibitor therapy with chemotherapy, or the tyrosine kinase inhibitor therapy, which we have to give. So these are all undergoing so that we can improve upon this, the recurrence rates. So we lower the recurrence rate and improve the cure rates. And in the unresectable patients, in the locally advanced, that is stage 3, when the mediastinal lymph nodes are involved, they are unresectable. Sorry for that. So they are unresectable. And when these unresectable patients are there, our goal of the treatment is to improve the progression-free survival, overall survival, and quality of life is to be improved. So here, this is the patient who's having a stage 3A disease, but stage 3B disease means it is very very big. It is involving the lymph nodes. It is not possible to remove all the things because the nodes are involved on the opposite side also. So these patients, stage 3B and C, they are all treated with the radiation and the chemotherapy. So a multidisciplinary team happens consisting of all the members. And then here, in fact, I would always include a primary care physician. We get in touch with the primary care physician so that he can advise the patients also and restore the confidence in him. So a definitive chemoradiation is the standard of care in the stage 3 unresectable patients. And then here we have choices. That means we can give radiation one and chemotherapy one after the other. Now this has been abandoned. This is no more given. Only when the patient is unable to tolerate the combination together, we give it. So earlier, about 10 years ago, we were giving chemotherapy followed by the radiation. And now we give radiation and chemotherapy together. So this is the standard of care, and the treatment takes lesser time. Takes about 6 weeks at best, and then the patient tolerates them very well. There are many protocols of giving different types of chemotherapy. The exercise is to manage the toxicity. And then after this, we were observing these patients and not doing anything till recently. So one of the trials which has used the durvalumab, that is, this is the molecule durvalumab. It's one of the immunotherapy agents, and then this was before we were giving the durvalumab. So before that, the overall survival rates at the end of 1 year was 34%. 2 years was 13%, 9% at the end of 3 years. So this was the overall survival. And then there was a need to improve upon this. So the trial which has examined the durvalumab, when it did that, you look at the percentages. At the end of 1 year, we have about 83% patients surviving. At the end of 2 years, 66 patients, and then 57%. So that's how this is a huge jump in the survival rate, and this unmet need has been now met, and this is one of the standards of care which has changed the entire oncology thing. So definitive chemoradiation followed by durvalumab is a new standard of care in stage 3 unresectable lung cancer. So this is for you to understand. And when the patients come to you for advice, tell them there's a huge jump. Though the cost has also gone up very high, the treatment toxicity will be there, but not so much with the durvalumab. But patients need to get, and the benefit is in terms of survival. This is what we must understand and pass it on to the patients as well. Coming to the stage 4 of the metastatic lung cancers. So what happens in these patients are almost 70% of the patients are diagnosed in stage 4 earlier. And then some of the patients come to the stage 4, ultimately meaning about 75-80% of the lung cancer patients at one time or the other get into stage 4. So the treatment goals in these kind of patients is, number one, extend survival, because cure is not possible. Cure is not possible in these metastatic patients, but we can extend their survival so that they can live longer. Earlier it was few months, and now it is coming to few years. Also, important goal is to maintain and improve the quality of life in these patients. Whatever cough, this pain and other symptoms are there, we must improve upon them and relieve all the severe and debilitating symptoms that he has. And at the same time, we must not give him too much of toxicity with the that agent that we have. So today we have very safe agents that we have. Stage 4 is now divided into M1A when it is having the contralateral lung nodule or a pleural effusion or pericardial effusion. And M1B is when single extrathoracic metastasis is present. M1C is multiple extrathoracic metastasis. Commonly, the metastases are found in the brain, bones, liver, adrenal, and kidney. So that's about the stage 4. And biopsy is a must. One of the myths which is floating around in almost all the patients is, sir, biopsy nahi karna hai. Please make them understand, without biopsy, we do not have a good marker to understand and we cannot treat them. So therefore, it is a very important thing. Tissue is an issue, or you can say biopsy is a must, and a proper biopsy so that all the tests for various things can be done. All patients must be looked and tested for oncogenic drivers. It takes from 1 week to 3 weeks. The time is coming down, but we can do this. And then there are various methods of testing them, from PCR and IHC to next generation sequencing, which may take a long time, almost 4 weeks in some centers. And then these are all centrally done in private institutes, so they do take time. And with the COVID and with the restrictions on the sending outside, there are some the delays also involved in that. We must accept it. But when the patient is having severe symptoms, the oncologist and pulmonologist may decide to treat him early with chemotherapy till the reports come. So those all things are personalized depending on the patient's condition. And while on treatment, whenever the patient has got a progression, that means the tumor starts increasing despite the treatment, one important thing is a rebiopsy. A question may arise from the doctors and from the patient saying, why are you doing another biopsy? Because during this time, we may have another mutation. The whole tumor molecular oncology may change completely, so that we may discover a new molecule, and therefore we can actually do the targeted treatment accordingly that time, because this tumor will be different from what it started with. And sometimes we are doing a liquid biopsy, which means a blood test is taken. From that, the DNA is extracted and sent for the molecular analysis, the way the solid tumor is done. Currently, the stage 4 management of the lung cancers is driven by the molecular testing. After the molecular testing, we have three situations. One is that he may have a kind of a driver mutation of any EGFR, ALK, ROS1, and so on, in which case he will be getting an oral targeted therapy against that particular gene. That is one. Second thing is a PDL1, a marker to know whether they will respond to the immunotherapy or not. And when this is high, we give any one class of the molecular and the immunology drugs. And then in case both of them are not present, which happens in about 30% of the patients, they get about chemotherapy. So doctors, you will realize that a lot of patients, when they are being investigated for this is the reason why it takes time. Based on the biopsy, based on the tests for the molecular markers, we decide what kind of a treatment is to be given: chemotherapy, targeted therapy, and checkpoint inhibitors. Remember one thing which we want to emphasize a lot, that if a patient has got this marker and we give him chemotherapy, his survival is not good. Similarly, if a PDL1 is high in the checkpoint inhibitors without any other markers, his survival is the best with the immunotherapy and chemotherapy together. And in the patients who have no markers like this, giving them any of these treatment is of no value, even though patients can afford it. So sometimes the questions come in saying that the patient, why don't you give immunotherapy? That's the latest drug. So here we have a marker which shows that immunotherapy will benefit or not. Similarly for the targeted therapy, which will benefit or not, and like so on. So this is important to understand. The survival has improved from 8 to 12 months in the patients who have the targeted therapy with the TKI anti-EGFR in one of the trials with osimertinib, which is a very safe molecule. We were defining our aims of treatment in these patients. It's not only improving the survival, but quality of life. If you have seen a patient ever getting the osimertinib or one of these TKIs, the patients are absolutely as if they are not getting any treatment. They are very safe, and then they improve a lot for almost 3.5 to 4 years. And here, the checkpoint inhibitors has also increased the duration to about 30 months. So imagine a patient who was expected to die in a few months. Now he's surviving for 2 to 3 years or maybe 4 years. And targeted therapy for adenocarcinoma depends on the driver mutation, depending on what mutation the patient has. And based on this, it's a long list of molecules which is present. And a lot of them are in the phase 3 trials. A lot of them are approved already. So we have a long list of molecules. Though this is complex, but this is the fact of life. Now, today we examine for all these molecules and then decide the course of management. And this is what exactly happens in the lung cancer clinic. A patient who does not have driver mutations, he will be getting either, depending on the PDL1 thing, he will get the chemotherapy and immunotherapy, or the anti-angiogenic agent and also immunotherapy. So multiple combinations are being tried, and different targets on the tumor cells are being targeted, so the patient gets the best benefit. So in summary, the treatment of lung cancer has evolved to the point that previously universally fatal patient, universally fatal disease has now become chronic illness, something like a diabetes, and for some kind of patients. So patients are getting treatment one after the others. We have the first line, we have the second line, we have the third line, we have the fourth line, and we have patients living on the fifth line as well of different molecules, and one after the other, depending on the type of the patient, the type of the cancer, the molecular marker present or not present, and the changing morphology. So there is a hope for future with less lung cancer. So patient is going to benefit a lot, and they have been benefiting. We have many patients who are actually living longer, and almost 4 to 5 years. And some of the takeaway points for the primary care physicians, that fewer lung patients are diagnosed in the earlier stages, which we need to improve a lot. It is at the moment their overall survival is still 10 to 15%. So we need to improve the diagnosis at the early stages. Maybe the screening of the high risk patients is important. Second thing is, early diagnosis of the patients of the lung cancer is important. And on an average, in India, the statistics have proven, various studies from PGI, Chandigarh, and many other places, including in Chennai, that about 4 to 6 months of ATT is given to most of the lung cancer patients, which is not a very desirable, not a pleasant thing to hear. So I think we need to have a high index of suspicion. Optimal referral to an oncologist and a pulmonologist is important. So must have a primary network with the patient. And important thing is a communication with these people, that is an oncologist and the pulmonologist, is very important for the patient. The largest unmet needs in the lung cancer were that improving the lung cancer literacy and awareness, that's important, and that's only possible by the campaign by the medical officers at all levels. Increasing access to the most innovative medicines which are available in the world. Earlier we were taking a long time in India to get the new medicine, but today, the moment it is announced and approved elsewhere, especially in US or anywhere else, it is available in India. And evolving how we think about the patient support to reflect the increased survivorship and enabling the early diagnosis of lung cancer, this is one of the most important things. So to conclude, management of lung cancer has changed considerably over the years. New concepts, molecular testing, therapy, they have come out of the age, and they have changed the whole scenario of the lung cancer. Tremendous improvement of the quality of life, the response rate, that is shrinkage of the tumors, the progression-free survival, and the overall survival. Patient who was living for few months now is living for few years, even in a stage 4 lung cancer. That's a fact of life. So we actually, the principle is a personalized therapy where the right medicine is given to the right patient, depending on the molecular markers. So therefore, biopsy is an important part of the lung cancer, not just once, at every recurrence. Primary care physician has an important and a very, very immense role, and very intimate role. He is is involved in the diagnosis, the decision making, the follow-up, prevention, screening, and early diagnosis. I think, and at every step, he has to hold the patient, and then he has to be communicating with the oncologist and the scene. So therefore, I will end with a statement saying the primary care physician is a very important partner in the management of lung cancer, and I'll be very happy to receive your feedback and suggestion in the email mentioned. Thank you very much.
So thank you, sir, for your elaborate presentation. It is my pleasure to introduce to you our second speaker today, Dr. Prashant Chhajed. Dr. Chhajed is a chest physician with super specialization in interventional pulmonology and sleep disordered breathing. He is also the founder of Lung Care and Sleep Center, Mumbai. He has also been an active clinical researcher in the area of interventional pulmonology, interstitial lung disease, obstructive airway disease, and lung transplantation. Dr. Chhajed has published more than 120 scientific publications in PubMed Index journals. He has presented numerous abstracts of his research at national and international meetings and has received numerous awards for his research presentations. Sir has been an invited lecturer at numerous international as well as national meetings, and is a well-recognized teacher and has been a faculty in numerous bronchoscopy and interventional workshops all around the world. May I now request Dr. Chhajed to deliver his presentation on the topic, Vigilance of Lung Cancer Detection and Indian Perspective.
So thank you very much, Dr. Verma, for this a very kind introduction. Now, I think I'm just going to share my screen. Can I share my screen now? No, I think I'm unable to share my screen. Apurva, you need to give me sharing rights.
Yes, sir. So you may try now.
Okay, perfect. So I think my screen is clear, right?
Yes, sir. Yes, sir.
Super. So once again, I think that was an excellent talk by Dr. Ranga Rao, and in which he has very clearly given an overview about the current management of lung cancer. People, we have had a nihilistic attitude towards lung cancer, but sir has very clearly shown the current approach, and that the improved survival is possible with all the newer therapies. And sir also touched upon an important point about the early diagnosis of lung cancer and the impact that can have on the survival. So I'm going to take it on from there. The point is we need to look for lung cancer at all times. We need to prevent the delays in the diagnosis of lung cancer at all the times. And we need to use all the newer technology and whatever we have at our disposal so that we can diagnose lung cancer earlier. And importantly, we should restrict our empiricism not for several months of therapy, but maybe for a couple of weeks of therapy if required, and then definitely go in for a tissue diagnosis to confirm microbiologically whether it's infection or whether it is cancer. So I'm now going to move on. This is a slide, I think, which Dr. Ranga Rao also showed you. Lung cancer is one of the most common cancers with the highest mortality worldwide. If you look at it again in this at this graph here, breast cancer is about 2.089 million new cases, and lung cancer 2.094 million new cases. So I think the impact of lung cancer is very high. The burden of lung cancer is very high. And if you look at the mortality, of all cancer deaths, lung cancer is the highest. 18.4% of all cancer deaths are lung cancer deaths, followed by colorectal, stomach, liver, and later on as breast cancer. So again, this part was also touched upon by Dr. Ranga Rao about the lung cancer in India. And we clearly see that in this year, in 2020, the estimated the diagnoses of lung cancer is almost 90,000, and there are going to be about 80,000 deaths related to lung cancer. And approximately 85% of all the lung cancers in India are non-small cell lung cancer, and which also Dr. Ranga Rao mentioned in the earlier lecture, that 15% are small cell cancers. Now, again, we come to the risk factors of lung cancer. We know that cigarette smoking is the most important cause of lung cancer, but 15% of the patients have never smoked. It could be because of an occupational factors, asbestos, radiation, etc. There could be genetic mutations which could be responsible, and the risk increases with combination of exposure to occupational carcinogens, toxins, and cigarette smoking. Another important thing is, we've always heard about in our medical school about scar carcinoma, for example, that, if there's a scar that can turn into a cancer. So people whose lungs are scarred by other diseases have also an increased risk of lung cancer carcinoma, and that could be TB, COPD, pulmonary fibrosis, and I will touch upon this as we go ahead further. Now, this is an important paper that was published recently. It's about COPD and lung cancer incidence in women. And it was very well shown here that overall women with COPD are at 1.64 times more likely to develop lung cancer compared to those who do not have COPD. So I think that's a very important paper which was recently published in the journal Lung Cancer. Now, when we look at this systematic review about, what is the impact of the previous lung diseases and lung cancer risk, I think this is also another very important paper that was published in American Journal of Epidemiology. It looked at 17 studies 25,000 cases, control, and about 80,000 control cases. Controls were there in the study. And what came out of this study? Now, really, a history of emphysema confirmed a 2.44 increased risk of lung cancer. A history of chronic bronchitis conferred a relative risk of 1.47 for lung cancer. Even tuberculosis and pneumonia were identified as risk factors that could potentially be potentially linked to an increased risk of lung cancer. Even people who were never smokers had elevated risks for emphysema, pneumonia, and cancer also. So what is this paper telling us? This paper is telling us and guiding us that, typically we are looking only at a history of smoking, for example, when we look for cancer. But we need to be vigilant. If somebody's got pulmonary symptoms, somebody has emphysema, somebody has chronic bronchitis, somebody has a past history of tuberculosis or pneumonia in the past, has got some scars on the, in the lung, then if the patient is not responding to conventional therapy in a couple of weeks, we need to investigate further, and we need to be sure that we are not missing upon lung cancer. So now, what are the symptoms of lung cancer? Typically there is no symptoms as such as which was suggestive or say firmly that it's an early lung cancer. Typically, it will be a cough that does not go away or get worse. That will happen with the cancer. That will happen with tuberculosis, for example. Coughing of blood can happen again in cancer. Can happen also in infection. Persistent infection, repeated pneumonia. If it's a post-obstructive, there's an endobronchial lesion, then there can be post-obstructive pneumonia, and somebody could have a recurrent pneumonia. So if somebody has a recurrent pneumonia, is elderly, then we must need to rule out an endobronchial obstruction. Somebody who's losing weight, somebody who has unexplained weight loss, somebody who's getting tired early. So these are the common lung cancer symptoms, which are not really only for lung cancer, but can be because of infection. But if we go ahead and evaluate these patients correctly, then we should be able to make either an infective or a cancer diagnosis. Now, it's very important, this is a paper which was, again, published in Chest in 2003. And what this paper showed is that there are about 25% patients with non-small cell lung cancer have resectable disease. And the rest of the 75% of patients are advanced disease. This was shown in 2003, and this was published in Chest. Now, I'm also going to share with you some Indian data, which we published in JAPI in 1999. And what did we find in this paper? Something very similar if you look at it. 74% of patients with non-small cell lung cancer were inoperable. That means the numbers are similar, whether it is the American study or if it is Indian study. 75% of the patients with non-small cell lung cancer are inoperable at the time of diagnosis. And why is it important? Why is the staging of cancer so important? Again, it is linked to the survival outcomes. And it was also referred to earlier by Dr. Ranga Rao that earlier the diagnosis, better is the survival. And I think this graph shows it so well. If you have a 1A1 survival, a stage 1, then your 5-year survival is 92%. And as you see, as the stage increases, or if you see here on the left side here, going downwards from 1A to 3A, 3B, the survival also reduces from 92% to 26% for a 5-year survival. And therefore, it's extremely important that if we want to improve the outcomes of lung cancer, that's not only going to happen with therapies, but that needs to be combined with an early diagnosis of lung cancer so that the patients can have a maximum benefit. So what is the significance of screening for early detection of lung cancer? Now, before I start talking about the lung cancer screening, the important point is, as far as India is concerned, I'm not aware of any particular guidelines or strategies or programs that talk about lung cancer screening in a very definitive way. Of course, there are small centers and hospitals which have their own strategies, own practical approaches, which are taken from the from the international guidelines and data, and whatever is done is best at a local level in screening for lung cancer. But I must say that it's still in infancy, and I think there's a huge potential to improve lung cancer screening overall. So what is the importance of lung cancer screening? The point is secondary prevention. most people who die from lung cancer are now former smokers. And if you see here, 50% of lung cancer diagnosis was made in former smokers. So what's the point? That even if the individual has stopped smoking, we should not close our eyes for lung cancer, and whenever appropriate, symptom wise, or if we are having a screening program, we need to include them also in the screening program. Now, for example, if you look at the 5-year survival, I already discussed with you, 1975, 12%, today is 15%. And again, if we need to improve this, we need to have an earlier diagnosis. Now, what are the fundamentals of screening for lung cancer? The idea is to detect the disease at a stage when cure or control is possible, to identify asymptomatic persons having the disease who can be further evaluated and the disease be confirmed. There should be a reasonable sensitivity and specificity and cost for the screening technique. It should be it should not be morbid for the patient to undergo the screening process, and the availability of effective treatment obviously should be there if you're actually looking for early lung cancer. So what are the screening modalities? The chest X-ray, there are several trials, the Mayo trial, etc., which looked at, regular chest X-rays to screen for patients with lung cancer, and early trials have shown that there is no mortality benefit if you do a radiograph. There are trials which have shown that even the chest radiograph and sputum cytology screening has not been shown to be a benefit. But I must say the strongest program for sputum cytology screening for lung cancer in high-risk individuals is in Japan. And to the best of my knowledge, that patients with moderate dysplasia or worse on sputum cytology are immediately picked up, and they undergo all the screening tests which are required, investigations which are required for the assessment and the detection of early lung cancer. I would say including autofluorescence bronchoscopy to identify any endobronchial early central lesions. The other technique which is onto the right side of the screen is a low-dose scan. And low-dose CT scan is something which has been very interesting and and we've seen a lot of data emerging over the last decade. So what is low-dose CT as a screening modality? It refers to a plain scan without contrast using a multi-detector CT scanner. It allows entire chest to be surveyed in a single breath hold with a scanning time of less than 30 seconds. The radiation dose is 1/10 of a diagnostic CT, and therefore it is called low-dose CT. And data from various observational studies and clinical trials have been published and demonstrate that screening with low-dose CT scan can identify early stage asymptomatic lung cancer. And I will discuss this in the subsequent slides. Of course, it also comes with challenges, and we might also refer to some of the challenges. So what are the key low-dose CT trials in the screening of lung cancer? What have we, what do the data tell us? All the trials, if you see here, this chart shows all the trials. I don't want to confuse you. I'm just going to give you an overview of the trials. Some of the trials compared low-dose CT scan versus no screening in high-risk individuals. And we will discuss in the next slides what high-risk individual means. And if you look at the pooled results, which compare low-dose CT to no screening or chest X-ray, there is a establishment of a survival benefit in the detection and also show an increase in the detection of stage 1 cancer. Amongst all these trials, the Nelson trial is the only fully powered randomized controlled trial that has published a 10-year mortality data, and I shall discuss that with you in the subsequent slides. This is the national lung screening trial, and this trial shows you the cumulative number of lung cancer deaths on this particular axis, and on this axis you've got years since randomization, and you clearly see that the curves for the chest radiography and the low-dose CT scan are separating out. That means there is an advantage of low-dose CT scan, and if you use low-dose CT scan to screen for early lung cancer in high-risk individuals, then that gives a mortality benefit. If you look at this, the next slide here is the Nelson trial. Now, this Nelson trial involves high-risk individuals, and lung cancer mortality was significantly lower among those who underwent a low-dose CT screening compared to those who did not undergo screening at all. So, based on these trials, which we've seen over the last 10 years regarding screening and low-dose CT scan screening, several societies have come up with recommendations. Now, there's a lot of text here in these recommendations, and again, what I'm going to do for you is I'm going to just give you a summary of these things. On one hand, you've got the American Society of Clinical Oncology, the ASCO, then you've got the ACCP guidelines, then you've got the NCCN guidelines, and then you've got the American Association of Thoracic Surgery. All these are important societies which are involved in the advocacy and the guideline formation for lung cancer. So what is it? The recommendation is high-risk individuals, okay, in all these groups. There may be a couple of years up and down, but the age ranges between 55 to 77 years. So somebody who's between 55 to 77 years and has a more than 30 pack year history of smoking becomes a high-risk individual. This individual may be a current smoker or might have also quit smoking in the last 15 years. So this is the basic recommendation, that if somebody fits into these criteria, then these individuals should be subject to screening of early lung cancer. Now, again, based on the guidelines for the high-risk individuals are, again, I told you, these are the age criteria. They could be active smokers, or they could have been, reformed smokers less than 15 years. And if they are more than age of 50 and have 20 pack years, but then if they have any additional risk factors, like a underlying chronic lung disease or an exposure to carcinogen, again, even if they have a less smoking pack year history, they would again become a high risk for lung cancer and would qualify for screening. So now, coming to in our scenario, what are the challenges for implementing low-dose CT screening in India? To my knowledge, we don't have any standardized protocol so far. And again, this morning I was discussing with Dr. Bhavin Jankaria also, and I asked him, he's also very active in the screening for early lung cancer. And he also told me that, on a personal communication, that whatever we are doing, we are following international guidelines and trying to adapt them into clinical practice. And maybe Dr. Ranga Rao later on in our Q&A or the panel discussion can comment further on that. So the problem or the challenges which we face are lack of awareness and a referral algorithm among general practitioners and physicians. There are concerns of overdiagnosis and false positive results. These are true concerns we have, because a lot of our inpatients in India will have a scar from a previous infection, would have a post-TB scar. And what do you do with those scars? And then once you find these scars, and these problems are not only restricted to India, but these problems are restricted to other parts of the world, that once you find a lesion on the CT scan, it could be cancer, it could not be cancer, and then one has to take it up further. Further investigation need to be done. You need to have an algorithm, also how to follow these up and whom you should do a biopsy for. And again, there have been concerns about radiation exposure from serial imaging, but we've seen that low-dose CT scan is 1/10 that of a conventional scan. And of course, you need an infrastructure, you need a referral process, and there's going to be a cost. And now questions, who bears the cost also of screening for lung cancer, particularly when in India, a lot of patients are still paying out of the pocket for the healthcare. Why is it important to have an early diagnosis? Now, you look at the left scan here, somebody who had a small, opacity here, and, if one would have, and is asymptomatic, you catch this in a high-risk individual, then you can either screen them and then decide in a multidisciplinary meeting, what to do next with this patient. But if this was not being evaluated at all, this potentially in few years' time could lead to a big lesion. And if you look at the PET scan down here with an, with a metastasis, and then these would come with a very poor outcome. So when we detect these solitary nodules on the scan, what are the diagnoses? Of course, it can be bronchogenic carcinoma, it can be metastasis, it could be a carcinoid, it could be lymphoma. But in our Indian setting, infectious disease are the most common. It could be, tuberculosis, it could be a past history, it could be an aerobic infections, and the list, it could be hematoma, it could be vascular malformation. The list is big, and therefore I would say, if there is going to be a low dose CT screening program, then clearly it needs to have a proper algorithm, and the patients need to follow a flow chart depending on the CT scan findings and the high risk status of the particular individual. Now, this is an extremely important study, which also Dr. Ranga Rao mentioned in this talk, the physician-related delays in the diagnosis of lung cancer. I mean, this is something which is in our hands. No, this is a study, if I'm not mistaken, which came from, I think, Vellore, and I think this is from Vellore, and based on 96 patients diagnosed as lung cancer in the Pulmonary Institute, less than half of the physicians suspected, 45% suspected lung cancer during the evaluation. Around 18% physicians made an incorrect diagnosis of tuberculosis, out of whom 88% had previous anti-tuberculosis therapy. 27% of the physicians referred the patients to a higher center for evaluation, and 78 out of 96 patients were inoperable at presentation, and only 11 patients were presented at the operable stages. And it was very clear that the pulmonary specialist was most likely to diagnose lung cancer compared to the other physicians, where the chances of a misdiagnosis was high. So when you look at this study which I referred to, there are other studies also which have been published from India, and I've listed them up in this table in a tabular form. And if you look at the data, the percentage of patients who can be misdiagnosed are between 17% to 52% of patients before they get a diagnosis of lung cancer. And the point is, the symptom to diagnosis delay, if you look at this column, it can be anywhere between 3 months to 6 months. So this is the period of delay which can be seen in the diagnosis of lung cancer. A delayed symptoms to diagnosis delay, and almost 50%, up to 50% of patients can be misdiagnosed initially. Again, I come to this important point, how do you differentiate between TB and lung cancer clinically? I mean, it may not be really possible to distinguish between both of them clinically, but of course, we can, categorize patients into a high risk of infection and a low risk of, and a high risk of cancer. And I think this is the table which shows, for example, the age. TB would be in a younger patient, cancer would be slightly in older patients. Fever in TB is evening rise. In lung cancer is not specific. In smoking history can be typically present in lung cancer, although most of you will agree that we start to see a significant amount of non-smoking lung cancer. So we should, if somebody is not smoking, we cannot discount the diagnosis of lung cancer. Weight loss can typically be very sudden in patients with lung cancer. Hemoptysis can be a late feature of advanced, of an advanced stage. And lymphadenopathy, when you palpate lymph nodes, if it's a solitary lymph node, they're likely to be TB. If it's likely to be cancer. And if it's a matted lymph node, multiple lymph nodes, then likely to be tuberculosis. And then these are other, symptoms. You could get backache and paralysis because of either pot spine or metastasis to the spine. So you really cannot differentiate. But the point is, whenever these symptoms are there, we need to really work up for infection or cancer. Radiologically, can be a difference. You can, in tuberculosis, more of a parenchymal disease. In lung cancer, it is more of a mass with or without collapse. You can get lymphadenopathy also in tuberculosis. You can get lymphadenopathy also in lung cancer. If you get a miliary pattern, then that goes more in the direction of tuberculosis. If you get that tree bud appearance, that goes more in the favor of pulmonary tuberculosis. And then, of course, if these things are not there, then you would suspect lung cancer. So tuberculosis is the most common reason for the delayed diagnosis of lung cancer in India. And unfortunately, many patients are still receiving empiric anti-TB for several months before they are referred or investigated for lung cancer. So, the typical feeling that, whenever we do these lectures and awareness programs, the typical question which is asked is, Doc, we can't investigate everybody. We need to, there might be a rationale in giving empiric anti-TB treatment. And then I would say, yes, whenever feasible, you must surely investigate as soon as possible. But in case you are thinking of your clinical judgment is in the direction of tuberculosis, and you've given a couple of weeks of anti-TB treatment, and if you don't have any the desired response, then I think there should be no further delay. This is my opinion in further investigating for confirmation of the tuberculosis, or for looking for alternative diagnosis, such as lung cancer, because I think even the patient deserves to have an appropriate appropriate diagnosis. So how do you differentiate between lung cancer nodules from others? I think we've discussed this. I'm going to go ahead in interest of time. I'll move this slide also ahead. And when we come to the CT scan, the central lobular nodules, the tree bud appearances, these are more in favor of tuberculosis. Larger nodules or mass-like lesions are more in favor of malignancy. However, from time to time, we've seen mass TB presenting as mass-like lesions also, and therefore the tissue diagnosis being more important. Lung cancers typically have an irregular speculated margins, and if you see these particular irregular speculated margins on the CT scan, then it is really a very high suspicion of lung cancer, and that in these such cases, one should not even consider giving empiric treatment even for a couple of weeks, and then should go ahead and confirm the diagnosis based on tissue diagnosis. So what are the imaging techniques that I use? X-ray we've discussed. There's no value in screening, but yes, when they're symptomatic, yes. CT scan and PET are extremely important. And as I see here, PET scan in our practice is now getting more and more importance. If you have a weight loss, if you have symptoms which are not resolving, you've got pulmonary symptoms, if you've got opacities on the CT scan, it could be infection, could be TB, and then you need to, and typically you need to make a tissue diagnosis. Often we might go ahead with the CT scan and go ahead and make a tissue diagnosis. And sometimes if the lesion is not very accessible, we also do a PET scan to find out which is the most, easiest site which can be sampled. So I think CT and PET are very important. CT has always been important. And now there's a very strong emerging role of PET CT to make the tissue diagnosis whenever lung cancer or even infection is suspected. When we talk about the bronchoscopic techniques for, how do you diagnose and stage lung cancer, the techniques, I'll just give an overview. You've got flexible bronchoscopy, you do BAL, you do biopsies, we do rigid bronchoscopies to remove an endobronchial tumor. That's not the point of discussion today, but yes, that is also possible. And then we use endobronchial ultrasound. The EBUS has become extremely important, again, in the diagnosis and the staging of lung cancer. And it's a technique which can also be used to diagnose and stage cancer in the same procedure. So now let me take you through a case. 58-year-old male who's an ex-smoker, has a history of myocardial infarction, has cough and copious sputum since 3 months, history of fever with chills is present. The sputum test is not conclusive. And if you look at this X-ray could be anything. This X-ray could be a cavitating mass lesion, or this could be tuberculosis. And in such a case, if you see here, typically this is the lesion which is leading to the bronchus, which is leading to the lesion. And in such case, if the sputum is not conclusive, one can just do something called a BAL, a bronchoalveolar lavage, where a bronchoscope is put into that particular segment and normal saline is being injected, as you see here, and then you aspirate it back, and then you send that for cytology and also for TB testing to confirm whether it is TB or whether it is malignancy. And in such cases, the yield of this simple procedure is very, very high. And of course, this can also be combined with a biopsy. Now, this is a 60-year-old male who's a smoker, had hemoptysis, had a normal X-ray, couldn't see anything. But because of hemoptysis, we say, okay, you need to get a CT scan. The CT scan also passes normal, and they said, oh, that could be a blood clot in the airway in the right main bronchus. So what we said is, okay, we've got a patient who's got hemoptysis, who's a male, who's a smoker, and we say, okay, let's do a bronchoscopy. And in bronchoscopy, what we found is, you see here is an endobronchial lesion. That's the only abnormal area, and it's an endobronchial lesion. And with a forceps biopsy, we could make a diagnosis of squamous cell carcinoma. So, again, if you see such a lesion, right, if you look at this X-ray, right lower lobe opacity, what it can be? It can be TB or it can be cancer. What do you do? If the sputum is inconclusive, we can do a BAL from here. And this is just for demonstrating purposes. We can do what is also called as a transbronchial lung biopsy. What you see here is a forceps which is opening up, and you take tissue bits. So a bronchoscopy in such lesions can also be of very good importance and give a diagnosis. Now I'm coming towards the last, some of my last slides here. Now, mediastinal lymphadenopathy, often an X-ray is done. You see there's mediastinal adenopathy, and typically, in India, the most, people just want to make an early diagnosis of tuberculosis for every mediastinal adenopathy. But friends, that's not true. It can be tuberculosis. Yes, the incidence is high, but it could be lung cancer, and it could also be lymphoma. And these, in this picture, trying to show you what mediastinal lymph nodes look like. So again, let me share a case with you. It's one of my old cases here. A 58-year-old gentleman who had presented, almost 10 years ago, had fever, left-sided pleuritic chest pain, was a non-smoker, and had a CT chest, which shows a left lower lobe consolidation here. And a CT-guided biopsy was done, clearly, because if you see a lesion which is next to the chest wall, it is just okay to do a CT-guided biopsy as the first step. But again, that was not conclusive. As you see here, the CT-guided biopsy just gave necrotic tissue, no granulomas, no malignancy, and it was TB negative. And what we see here is what I'm sharing with you is a technique called EBUS TBNA, which is done under local anesthesia, conscious sedation. And what we do with this technique is this is a bronchoscope with an ultrasound probe here at the tip. And with this, we can perform a mediastinal ultrasound. And with the mediastinal ultrasound, we can actually detect lymph nodes in the mediastinum and then take biopsy. So this is what we did for this particular patient here. This is called an EBUS. These are the early papers of EBUS TBNA, which we published in 2002 and 2004, and has a very high sensitivity of 95% and specificity of 100%. So for this particular patient, we did a whole PET CT, because the chest CT was not conclusive. A PET CT was done. The CT-guided biopsy was not conclusive. And what this showed was the perihilar uptake of the FDG on the PET scan. And then what we did is, because this was peribronchial, we could use the EBUS to take a sample here. And after doing the EBUS TBNA, we could make a diagnosis of adenocarcinoma. And clearly, immunohistochemistry could be done. And we could make a confirmed diagnosis of adenocarcinoma lung. So this is a paper which we did subsequently and published, where you can get good core biopsies if you use the EBUS TBNA technique. And what we do for these core biopsies. So EBUS can give core biopsies, and we have shown you in these pictures here that these core biopsies can be subject to histology, can be subject to microbiologic testing for TB cultures, TB gene experts, and also for molecular tests, as I will share with you in the subsequent slides. So EBUS TBNA samples, if you see here clearly in these two papers, and there are several papers which have come after this, you can send them for EGFR testing. You can also do ALK testing. These are biomarkers, and you can also do PD-L1. So these are the biomarkers or molecular markers which Dr. Ranga Rao also mentioned in his lecture. And the testing of these biomarkers is important to guide targeted therapy or immunotherapy or checkpoint therapy. So this is a review article which we published some years ago on EBUS TBNA in the diagnosis and staging of lung cancer. And I think EBUS has been really a revolution in terms of doing a diagnosis and the staging of cancer in the same setting, and at the same time getting adequate tissue for doing molecular testing, which can help with targeted therapy and immunotherapy. So once we get these tissue samples, what do? We send these samples for cytology and histology. Mind you, often we are always discussing about whether it is TB or cancer. So we do cytology, histology, and often we send these patients for TB gene expert and TB cultures also. And in India, in the paper which I showed you from 1999, we had 7% of the patients in whom a diagnosis of TB and malignancy was made at the same time. So it is not unusual to have two coexisting problems in our Indian population at the same time. And therefore, whenever sending samples, whenever it is clinically appropriate, there should be a low threshold to send the sample for TB gene expert and TB culture. And aerobic and fungal studies can be sent as appropriate. And one more thing, we would like to do is now, whenever we are doing biopsies and the pre-test probability of it being lung cancer is high, we have now started to take extra biopsy samples and store them. In case it is an adenocarcinoma, this extra tissue may be required for molecular testing, and so that the patient doesn't have to come back for another procedure. And therefore, whenever we are making a diagnosis of lung cancer, we've now moved away from doing just a fine needle aspiration, as an FNAC. We've now moved to biopsies and having adequate material for the diagnosis, for immunohistochemistry, and for molecular marking. So the take-home messages from this are: lung cancer is a very common disease. I've shown that to you. It's very aggressive. If you don't diagnose it early enough, then the outcomes are very poor. At the same time, I've shown you that early detection is associated with better outcomes. Screening using low-dose CT scan is picking up in many parts of the world, and hopefully, we will have some algorithms and guidelines on how we could potentially start implementing it in India. Of course, it comes with several challenges of false positives and what we do with the false positives. But then, it's an area which is evolving and something that we will need to tackle as we go ahead, because low-dose CT has been shown to have a mortality benefit also. Lung cancer is usually mistaken for TB, leading to a wrong diagnosis and wrong treatment. And one must know the differential diagnosis of pulmonary nodules whenever, as physicians, you're faced with pulmonary nodules on the CT scan. Of course, you think of TB and also you think about cancer, but then you may also need to be aware that it can be things other than TB and cancer. And therefore, I would recommend that whenever a case is suspected of lung cancer, an individual who's been on therapy is not responding to the current clinical treatments, and then these patients deserve to be worked up further, microbiologically or histologically or cytologically, to confirm the diagnosis of tuberculosis or cancer. Thank you very much for your attention. And I'll be very happy to take further questions along with Dr. Ranga Rao.
Thank you very much, Dr. Prashant Chhajed, for your elaborate presentation. I think you have covered on different aspects, right from the screening and also some of your practical cases related to differential diagnosis, or what are the advances in the diagnosis of tuberculosis in terms of EBUS and different techniques. And also thank you, Dr. Ranga Rao, for giving an overview on the recent advances and importance of doing tissue testing, as well as the different therapies which are available for management of lung cancer, including the targeted therapies and the immunotherapies. I think lung cancer is one of the important causes of mortality in India also. And if we do a PubMed search of lung cancer, just the word lung cancer, we get 350,000 articles which are related to lung cancer on PubMed. So really a lot of research work is going on in lung cancer. So I'll move to the question answer session. And I'll just see what are the questions which we have received from the audience.
While we are doing this, I must say, Dr. Prashant, your lecture was absolutely elaborate and fantastic. I really enjoyed and learned a lot of things. Very, very good things you have covered: screening and the whole techniques of the bronchoscopy, and then early diagnosis, distinction between the pulmonary tuberculosis and lung cancer, which is most important for a primary care physician. I think wonderful. I really enjoyed, and congratulations for delivering such a good lecture.
Thank you very much, sir. Thank you very much.
Thank you. So I would request audience to post their question, and meanwhile I will read upon some questions which are there in the chat box. So one of the questions from Dr. A.K. Gaur is how effective is chemotherapy in EGFR mutated NSCLC patients?
Okay. Thank you, Dr. Gaur, for the question. He's from which place?
It is not mentioned, sir.
Oh, doesn't matter. So, Dr. Gaur, and everyone else, today's thing is that whenever EGFR mutation is present, especially the sensitizing mutation, the first recommendation is to use the EGFR anti-EGFR TKI. And the category 1 recommendation or level 1 recommendation is to use one of the best molecules which is available called osimertinib. And then these other thing is recently 2 trials have come, one from Tata and one from Japan, saying that chemotherapy and the gefitinib, an anti-EGFR TKI combination, also would do quite fine. So these are the 2 things that we have. And then we have other molecules called afatinib and so on. They also can be used. Your question was related to chemotherapy. If you give chemotherapy alone in EGFR mutant patients, it is inferior to a TKI. And then whereas if you give a combination, it will be better than a single agent gefitinib. Trials are going on to combine osimertinib with chemotherapy. So answer is very clear cut. Only giving chemotherapy is not appropriate in such patients.
So Dr. Ranga Rao, if I may ask, I mean, so if somebody is, EGFR positive, so what is the standard of care at present? Do you just give a TKI, or is it important to give both simultaneously or one after the other?
Okay, so the best recommendation for a patient would be to give osimertinib if they can afford, and then osimertinib has got the best quality of life and very long overall survival as well as progression-free survival. Gefitinib gives much lesser survival, and gefitinib with chemotherapy gives a survival of about 20-24 months, and then whereas osimertinib crosses about 24-28 months. So that's the advantage. So and then once these fail, then we go on to repeat the mutational analysis and go for the next line agents. Next line agents could be another anti-EGFR or immunotherapy or chemotherapy.
So if I understand correctly, if somebody is getting gefitinib, if you can't afford the earlier molecule, then it is gefitinib plus chemotherapy and not gefitinib alone.
That's what 2 trials have shown, gefitinib and chemotherapy, provided the patient is in good general condition.
Okay. Thank you.
So, Dr. Ranga Rao, there's one more question for you from Dr. Urvashi Tandon. She's asking if the carina, pre and paratracheal nodes are increasing in size and they are around the major vessels, can we give radiation?
Yes. So radiation can be given. So first thing is we must prove that this node is metastatic, not an infective, not a tubercular. That's the important thing, which we do it recommended by the EBUS, what Dr. Prashant was mentioning. So confirm that histologically this is malignant, and we can easily and very well give the SBRT to these patients. We have been giving and use the radiation with very modest, now modern techniques. You can use the radiation, yes.
Okay, we have one more question from Dr. Fatima. She's asking, what are the alternative chemotherapy regimen available for small cell lung cancer?
Okay, so chemotherapy, the standard is the etoposide and cisplatin or carboplatin, depending on the age of the patient, the status of the kidney, and so on. The irinotecan as a third line has been tried. It is very toxic. It is not usually given, but if the patient is in a fit condition, we could try that with a little marginal improvement in the responses. But another current one is cisplatin, etoposide, or etoposide and carboplatin, along with a new immunotherapeutic agent, that is atezolizumab. So that is one of the new standards of care, and where it has improved the PFS as well as the overall survival for the first time in the small cell carcinomas. But this is limited to the extensive stage only.
Okay. So we have one question from Dr. Anil Kukreja. Maybe Dr. Prashant can take this. Can artificial intelligence of X-rays or CT scan help in improving early diagnosis of lung cancer?
See, I mean, it's always, very attractive to talk about artificial intelligence, etc., of X-rays and CT scans. But I think, yes, eventually, more than X-rays, I think it is likely to be in CT scans, I think. That if you have a CT scan, what are we looking for in the AI? We want the AI to tell us what is the likelihood of this lesion to be malignant. Today we are doing that based on the descriptions which I showed you, the size of the lesion, how much is the, the growth rate of the lesion, how much is what is the border of the lesion, whether there is calcification, non-calcification, all these factors are there. So what are we looking at? We would really like an AI algorithm which would tell us that the probability of this being malignancy is very high and that this should be investigated further. And there are a lot of people who are working on this, and I think this is an area to which all of us will really look forward to.
So, Dr. Prashant, so one question is on the staging part. If a patient comes to you normally, what would be your workflow of evaluation of the patient to have a proper staging of that lung cancer patient, typically in your routine OPD?
See now, whenever we talk about staging, there are two things which are extremely important. One is the staging based on the imaging modalities, what the imaging is suggesting to us, and then the second is the tissue staging. And it's a very important question that is being asked. So I think a lot of the patients, once there is malignancy, we are always going to talk about either a CT scan or a PET scan. In some of the patients, before we do go for the tissue diagnosis, we do have only the CT scan in front of us because we are not sure what it is, and we go ahead and make a diagnosis, and then the patient may land up with a PET scan later on. There are certain situations now that PET is emerging as a very attractive modality to choose which is the most easiest or the best way to get the tissue diagnosis. Often it might be that the patients have already come to the PET scan. Now, suppose you've already got a diagnosis of TB, of malignancy, and then you've done a PET scan. Now, is the PET scan staging enough? The reason is typically what we see in the mediastinum, as was shown also by Sir, is it's really important that if there are mediastinal lymph nodes, then it is possible that a PET positive lymph node may not harbor malignancy, and it is possible that a PET negative lymph node may harbor malignancy. And therefore, if suppose a patient has got distant metastasis, he's got bony metastasis, it's a different story. But when you are looking at somebody who could be potentially operable versus potentially needing something new adjuvant, I think that is the time, even after a PET scan, you need to go in and get a tissue diagnosis. What is more attractive, or what is very important right now here is the EBUS, what we are doing. So we are doing EBUS TBNA to confirm whether a PET positive or a PET negative lymph node is harboring malignancy or not. So that is the algorithm, I would say, to simplify. It's imaging. It's for mediastinum, we do a EBUS TBNA. Sometimes we do what is called an EUS BFNA. That means the same bronchoscope can be passed into the esophagus, and we can look also and take biopsies of samples of lymph nodes which are not accessible by EBUS TBNA. So the same scope can be used to take tissue diagnosis. What more can be done? Sometimes if you're not sure, you don't have lymph nodes here, you've got a peripheral lesion, you might do a CT guided biopsy. Even that is good enough. You might have a neck lymph node, you might do a lymph node biopsy. The point is that always, whenever possible, if there is a site of a metastasis, a tissue diagnosis should be obtained if that is going to help you to make a treatment decision. And often, as I said, in a small percentage of patients, we can also have a coexisting infection, and that also needs to be kept in mind.
Sir, this question is very simple question, but it is a very apt question posted by an anonymous user. The simple question is, Dr. Ranga Rao, sir, you can take this. When should we refer a patient to oncologist, and at what time? And what is the characteristic of a patient which we should refer to oncologist? So
I refer you to Dr. Prashant's lecture as to when to suspect the lung cancer based on the symptoms, based on the radiological diagnosis. So clinical, I'll just summarize. One is the opaque hemithorax. Whenever there's a big mass, where there is a massive effusion, suspect the malignancy. That is one. Second thing is a lung shadow which is not looking like a tuberculosis, not caseating, not cavitating, and then patient is unwell. So I think you should just send him for the malignancy, the evaluation. And also just a coin shadow or a rounded shadow with or without symptoms must be sent. If there is a lung lesion with a lymph node, especially if it's a hard one in the supraclavicular, you must. And if there is a lymph node, the radiology shows a mass with mediastinal lymph nodes, again, you must send him to evaluation. So these are the things. And then, of course, they show metastatic spread to the bones or liver or brain or these things, we can do it. And sometimes we come across patients of extremes. One is that patient is asymptomatic, just do an X-ray and there's a solitary pulmonary nodule. So it could be the earliest lung cancer. At the same time, the patient lands up in a neurosurgery ward because of a seizure. And then when his CT scan or MRI is done, he's got a lesion in the brain. And when that is operated upon, we come to know that this is metastatic adenocarcinoma. Retrospective evaluation shows that he's got a disseminated lung cancer. So many situations are present. So I think clinician has to have a high index of suspicion. So whenever they have persistent respiratory symptoms, persistent radiological signs, he must be referred to the pulmonologist or the oncologist at the earliest. And sometimes they think that this is tuberculosis. Patient is not responding. Patient gets hoarseness, supraclavicular node, and so on. Please suspect the malignancy and send them very soon.
So, Dr. Prashant, I would like you to clear this common myth for our audience that only men who have a history of smoking can get lung cancer and women non-smokers cannot get lung cancer. I know you've covered it in the presentation, but once again for our audience.
Yeah, so I think, now there are several myths about lung cancer, that only smokers get. Yes, smokers are at an increased risk of lung cancer, that is clear. But at the same time, even we are seeing a lot of non-smoking lung cancer, and I already referred to that in the lecture. So the non-smoking cancer, when we did our study and we published a study in '99, that is almost many years ago now, at that point also, it was very clear that we had more in the women. So we had women, non-smokers, who were having an increased lung cancer. And already in '99, we had shown that adenocarcinoma was increasing in the numbers. So that was a changing pattern. Earlier in medical school, we were taught squamous cell carcinoma was the most commonest cancer. A lot of things have changed. So, squamous cell carcinoma is central, adeno is periphery. Now, I think those rules are not applicable anymore. So again, similarly, you may have a smoker who's having cancer. Yes, high likelihood of having squamous cancer, but now we have smokers also who have a lot of adenocarcinoma. So smokers are at increased risk of lung cancer, but because an individual is not a smoker or an individual has a past history of smoker, it does not reduce, it does not say or rule out, I would say, the risk of having lung cancer. And therefore, I would recommend that, in clinical practice, if somebody is, being treated with a particular clinical judgment, if that individual is not responding appropriately to the clinical treatment the patient getting, I think we need to confirm. It could be anything. It could be cancer, it could be infection, whatever it is. But I think we need to start investigating them earlier.
Dr. Ranga Rao, Dr. Anand Agrawal wants you to elaborate on a single coin-shaped lesion and how to approach it.
Right. So if the patient, I am presuming that this patient is asymptomatic. In fact, we had recently a patient like this. So the patient was not having any symptoms, and an incidental X-ray was done for some other thing. He had gone to for hernia, and then when X-ray chest was done, there was a coin shadow. So how do we do? The first thing is we do a CT scan, and then understand by radiological imaging as to whether this is benign looking or it is a malignant looking. If it is peripheral, then definitely we do a CT guided biopsy or an FNAC at least to know what is it, tuberculosis, it is a malignancy, and so on. If it is a central lesion, then the first thing we would do is refer him to the pulmonologist for a bronchoscopy, a ball, and then also the transbronchial biopsy. So, or EBUS, whatever is possible in that. So getting to know whether this is tissue or not, that is the first step, histology. So take it for granted that this is the solitary pulmonary nodule, which is adenocarcinoma. Then the next thing is, what is the stage of this patient? And then because this is looking like an operable lesion, he must be subjected to surgery. Before he is subjected to surgery, we must be very sure that he does not have metastasis anywhere in the body and including the brain. So we do an MRI brain with a contrast and then a total body PET scan so that we rule out all the pulmonary metastasis, evaluate his lung function test, and then refer him to the thoracic surgeon so that he can have a surgery. In some patients who are unfit, they may not be fit for the surgery. In elderly patients, bad lung compromise and so on, in that case, we subject them to a radiation, that is SBRT or the RFA and so on. So like that's how we proceed. But local treatment for a solitary pulmonary nodule is important after the confirmation of a malignancy.
Okay. Just a quick concluding remark from you both. First, Dr. Rao and Dr. Chhajed for our audience.
From the oncology side, the lung cancer management has completely changed. And then we have seen in the last 3-4 decades that the patient who was dying so early now is living for years. I just want to actually, time didn't permit, otherwise I have a couple of patients who has been treated on the osimertinib, has lived for 4 years before she succumbed to other things. Another patient who had 3-4 lines of chemotherapy has immunotherapy, and then now he was not able to go. He came in the wheelchair, and now he's going to play golf every time he gets immunotherapy. It's 2.5-3 years of the immunotherapy he had. So now that kind of a magical change in the lung cancer which has happened, we have witnessed it. So lung cancer is completely changed over the years, and most important thing is getting the tissue from wherever and whenever it is possible, getting adequate tissue, sending it for good analysis so that we have the driver mutations, PDL1 and all the estimation, and then deciding the treatment. So personalized therapy for the lung cancer is the key. After the histological diagnosis, giving the optimal treatment depending on what the patient stage and the type of cancer it is, that is the next best treatment. And then a good follow-up, and then primary care physician, pulmonologist, radiation, medical, surgical, pathologist, radiation, and the multidisciplinary management of a lung cancer is very important. At the same time, I'll hand over to Dr. Prashant for the early diagnosis and screening. Thank you very much for this opportunity. I enjoyed and got educated, especially from Dr. Prashant's lecture. Thank you.
So likewise, I also learned a lot. I think the messages from my side, the concluding remark would be, I think just a summary of some important points which I mentioned during the talk. I think it's really very important for us to understand that we cannot any longer have prolonged empiric treatments, particularly if they are not responding in patients who are not responding to therapy. Now it's really important to make a diagnosis. It could be a lung cancer diagnosis where we've clearly shown that, that there's an advantage or a mortality benefit if you diagnose them early. So that's very clear. And like Dr. Ranga Rao said, there are so many new therapies which have come in, and therefore it's important to make the diagnosis. It's not only about making the lung cancer diagnosis. In clinical practice, that lesion could be infection. Most common is TB. Depending on which area you are, it still could be TB you're treating, but that could be MDR TB, drug-resistant TB. So the message I want to put across is, if you look at the studies, the delay time from the onset of symptoms to the patient getting a diagnosis is almost up to 6 months. We need to reduce that. We need to make that into a few weeks, less than a month, so that we are fair with patients. The disease is not progress. If it is an infection, it's a particular infection, we need to treat it appropriately. If it's cancer, we need to diagnose it appropriately. I would really like to conclude with one case. Somebody very close to me, my childhood friend, went for a health checkup, said there was some CP angle blunting was there, and he had absolutely no symptoms at all. Yes, he used to smoke off and on, and so in the health checkup they said to see the physician, and the went to the GP and was discussed to start anti-TB treatment. When he spoke about anti-TB treatment, he said, "Oh, my friend is a chest physician, comes to me." And then I said, "No, I don't endorse this. We need to work up." And the most unfortunate thing that happened after making the diagnosis was that he had cancer. The pleural fluid showed cancer. So just imagine if this gentleman would have been already on therapy, on anti-TB treatment, we would have just prolonged and delayed the diagnosis. It's almost 4 years now. He turned out to be ALK positive, and he continues, his battle with cancer. So friends and colleagues, I would strongly recommend that in today's era, we need to go for the microbiological diagnosis or the cell type diagnosis, histological diagnosis, whenever we are dealing with any opacity on the X-ray or the CT scan, as much as possible. Thank you very much.
Okay, so we are already past 7. My sincere apologies to all those whose questions I couldn't take because of paucity of time. But thank you so much, Dr. Ranga Rao and Dr. Prashant Chhajed, for wonderful presentations. I'm sure all of us have immensely benefited from this webinar, and we are now successful. We are quite successful in achieving our objective, as now the participants know all the essentials of lung cancer. Thank you all for patient hearing. Enjoy your evening. Keep healthy, keep safe wherever you are. Goodbye.
Dr. Ranga Rao, it's an honor to share the platform with you.
Yeah, same here, absolutely same. Pleasure is mine.